Welcome back to the deep dive. Today we are taking a necessary plunge into one of the body's most critical anatomical crossroads. We're talking about that junction where the chest ends and the abdomen begins. We'll be mapping out the abdominal esophagus and the stomach, pulling everything straight from foundational texts like Gray's Anatomy. So our mission today is to build a complete mental picture of this whole region for you. The structures, their relationships, the blood vessels, all of it. And the goal is to do this without a single visual aid. So you can just close your eyes, listen, and let us build you that three-dimensional map right in your mind.
And this area is, it's absolutely foundational. We're covering the entry gate to the entire GI tract.
Yeah.
This is the point where swallowing ends and all that primary chemical and mechanical digestion really kicks off. And these structures, they're defended by these unique multi-layered sphincter mechanisms. They have one job: keep highly corrosive acid right where it belongs. So understanding their orientation, their proximity, it's critical for diagnostics and especially for surgery, whether you're dealing with simple reflux or, complex surgical oncology.
Okay, let's start right at that entrance then, just below the diaphragm, with the abdominal part of the esophagus. What always strikes me is just how short it is.
It is incredibly short.
It's barely there, maybe 1 to 2.5 centimeters long.
Exactly. It's surprisingly short, but it makes up for that in structural importance. Spatially, you have to picture it a little to the left of the midline. It runs obliquely, so sort of forward and to the left, before it just ends at the cardiac orifice, usually right around the T11 vertebral level.
So even though it's that short, it can't just be floating there. What's holding it in place? What stops it from moving around every time we breathe?
That is the job of a really crucial anchoring system: the phrenico-oesophageal ligament.
The phrenico-oesophageal ligament.
Yep, think of it like a thick, specialized collar made of connective tissue. And it has two distinct layers, which is key.
Okay, so tell us about these layers. How do they actually create that stability?
It's basically a dual anchor. The proximal layer, the one closer to the head, is thicker, and it descends from the endothoracic fascia. That's the fascia from inside the chest.
Okay, so coming from above.
Coming from above. Then the distal layer, which is thinner, ascends from the transversalis fascia below the diaphragm. They meet and they fuse, surrounding the esophagus at the hiatus. This whole arrangement just tethers the esophagus firmly, limiting its vertical movement. And that's a huge deal for surgeons working on hiatal hernias or anti-reflux procedures.
That anchoring function sounds like a major surgical checkpoint. So for a fundoplication, for instance, the surgeon is laser focused on that tether.
Absolutely. To even mobilize the esophagus for these procedures, you have to breach or divide that ligament. It's common for surgeons to actually reinforce this anchor. They'll place sutures between the esophagus and the left crus of the diaphragm. And for visualization, just remember its immediate neighbors. Anteriorly, it's sitting right behind the left lobe of the liver. Posteriorly, it's resting directly on the left crus of the diaphragm.
Okay, here's where it gets really interesting and surgically very sensitive. The vagal trunks. They are right there in the neighborhood. What makes them so hard to protect during surgery?
The risk of injuring them is really high, and the damage can lead to chronic, miserable issues for the patient. Things like gastro-paresis, where the stomach just doesn't empty properly, so you have to know their clock positions. Imagine you're looking at the esophagus end-on, like a circle.
Okay.
Let's start with the hard one. The anterior vagal trunk. It's mostly derived from the left vagus nerve, and it's often described as being thin and thread-like.
So it's delicate.
Very delicate. And because it's so fine and it's stuck so closely to the muscle coat of the esophagus, usually around the 2 o'clock position, it is incredibly difficult to spot and protect. You have to actively hunt for it.
A definite risk area because it just blends in. What about the posterior one? Is that any easier to find?
Thankfully, yes. The posterior vagal trunk is generally more substantial. It's bigger. And it's easier to spot because it's usually lying in some loose connective tissue just behind and slightly to the right of the esophagus. And that little bit of separation, that loose tissue, gives the surgeon a bit more of a margin to see it, to protect it, and keep it intact.
And both nerves are obviously vital.
Vital. They carry all the parasympathetic signals that control motility and secretion for the whole downstream GI tract.
Okay, let's move inward, down the esophagus to that internal transition point, the gastro-oesophageal junction. This is defined by a landmark you can actually see, the zigzag or Z-line. Help us visualize that transition.
Okay, so imagine two completely different types of internal lining meeting, just abruptly. The esophagus has this protective, pale, pink, squamous epithelium. It's designed for transport.
Right.
Then the stomach has this thick, red, glandular columnar epithelium designed for acid. The Z-line is that messy serrated border where those two colors and cell types crash into each other.
And guarding this junction is the lower esophageal sphincter, the LES.
Yeah.
It's not just a single muscle, is it? It's a high-pressure zone maintained by a really complex defense system.
It is. It's a collaboration between two main components. First, you've got the intrinsic muscular part. This is specialized, tonically contracted, circular smooth muscle, the distal esophagus. And this thickening is even more specialized. You have what are called clasp fibers on the right side and sling fibers on the left, which actually come from the oblique muscle layer of the stomach. They wrap around and anchor it internally.
So that's the internal muscular seal. What provides the external pinch?
That's the second component, the extrinsic mechanism. This is the reinforcing squeeze from the encircling fibers of the right crus of the respiratory diaphragm.
So the diaphragm itself.
The diaphragm itself provides a physical external squeeze that reinforces that high pressure zone, especially when your abdominal pressure goes up or when you breathe in. And, there's also a minor third factor, the acute angle of his. That's the cardiac notch. It acts like a simple flap valve, pinching the entrance when the stomach gets full.
So when this complex three-part gate fails, that's when we get reflux disease and often these anatomical defects. Let's talk hiatal hernias. What's the key difference between the common sliding type and the more problematic paraesophageal type?
The difference is all about what's moving. In a sliding hernia, which is about 90% of cases, the entire junction, the abdominal esophagus, the cardia of the stomach, slides upward through the hiatus into the chest.
The whole thing just moves up.
The whole anchor is lost. It just slides.
And for the paraesophageal hernia?
Here, the key is that the esophagus and the pylorus often stay put, right where they're supposed to be. But a separate part of the stomach, usually the fundus, herniates up alongside the esophagus.
Ah, right.
And since the ends are still anchored down below, this hernia sac is much more likely to twist, get obstructed, or even strangulated, which makes it a surgical emergency.
Now what about the opposite failure? Achalasia. The gate just won't open.
Right. Achalasia is impaired relaxation of the sphincter. It's caused by a loss of the inhibitory neurons in the wall, meaning the sphincter just stays clamped shut. So patients suffer from dysphagia, trouble swallowing. And when you image it, you see the classic result. A hugely dilated esophagus that tapers down sharply to that constricted sphincter. It creates what they call the bird's beak appearance.
And finally on this, chronic acid failure can lead to a really serious pathological change. Barrett's esophagus. You mentioned the Z-line earlier. This is basically a loss of that protective boundary.
That's a great way to put it. Because of that persistent chronic acid exposure, the protective pale pink squamous epithelium gets pathologically replaced by metaplastic columnar epithelium.
The stomach lining starts creeping up.
Exactly. The kind of cell that belongs in the stomach or intestines is very strongly correlated with chronic reflux, and it's the most important precursor lesion for esophageal adenocarcinoma.
So now we are through that gate and into the stomach itself. This is the widest, most muscular part of the alimentary tract. It's situated across, 3 upper abdominal regions, left hypochondriac, epigastric, umbilical.
That's right, and it's a huge reservoir. It can store up to 1.5 liters of content.
Let's map out the parts for visualization, say, from top to bottom.
Okay, so the highest point is the dome-shaped fundus. It projects up and to the left of the cardiac opening. That's where you often see the air bubble on an X-ray. Below that, you have the large central body of the stomach.
And the body extends down to a landmark.
It does. It narrows down towards the angular incisure, which is this constant sharp notch you can see on the lesser curvature. This notch marks the transition into the outflow region. First, the wide pyloric antrum, then the short, narrow pyloric canal, which is only about 1 to 2 centimeters long, and that terminates at the dense ring of the pylorus itself, usually level with L1.
And the stomach has these 2 crucial borders defined by its curvature. The lesser curvature is the shorter medial border, and that's the attachment for the lesser omental.
And that's critical because the lesser omentum is the house for the right and left gastric vessels.
Right. Then there's the much longer, greater curvature.
No, it's longer, 2 or 3 times the length. It arcs up, defining that dome of the fundus, and then sweeps down. Laterally, it attaches to 2 really important ligaments, the gastrosplenic ligament up top, and then further down the expansive greater omentum, which carries the right and left gastro-omental vessels.
Let's talk surroundings. If we could just lift the stomach away, what would we see immediately behind it? I hear this area called the stomach bed.
The stomach bed is that shallow recess of structures that the back of the stomach rests on. But they're not usually touching directly. They're separated by the omental bursa, or lesser sac.
Which allows it to move.
Exactly. It allows the stomach to distend and slide around. And the bed itself consists of the diaphragm, the left suprarenal gland, the top of the left kidney, the meandering splenic artery, and the front of the pancreas. That's a lot of critical anatomy in one small space.
And this mix of mobility and ligamentous tethers sometimes can go wrong. Gastric volvulus.
Yes, volvulus is just an abnormal pathological rotation. The most common type is organoaxial volvulus. It rotates along the line connecting the cardia and the pylorus.
So like rolling a towel along its long axis?
That's a perfect analogy. The greater curvature flips up superiorly. The less common type is mesentero-axial volvulus, where the stomach rotates around its body axis, sort of like spinning a football. Both require those omenta and ligaments to be pathologically lax or missing.
Okay, let's unpack this. The stomach's blood supply. Anatomists always seem to celebrate the stomach for its resilience. Why is it so resistant to ischemia compared to, say, the intestines?
It's because the arterial supply is just incredibly robust. It comes almost entirely from the coeliac trunk, and it forms two extensive, continuous, and anastomotic arcades along the curvatures.
The double loop.
A double loop. This redundancy means blood flow is guaranteed even if multiple feeding branches get blocked.
So map out those two circumferential highways for us.
Okay, we have an inner circuit and an outer circuit. Along the lesser curvature, that's the inner one, the main feed comes from the right gastric artery, usually a branch of the proper hepatic joining with the left gastric artery, which is the smallest branch coming right off the coeliac trunk.
Inner circuit, check. What about the outer one?
The second larger circuit is along the greater curvature. Here, you have the right gastro-omental artery from the gastro-duodenal, meeting the left gastro-omental artery, a big branch from the splenic artery. And to complete the picture, the fundus gets its own dedicated supply from about 5 to 7 short gastric arteries, which also come right off the splenic artery.
That system is just built for backup. But let's look at the flip side. A pathology that can still cause massive bleeding despite this strong supply. The Dieulafoy lesion.
The Dieulafoy lesion, it's a specific, dangerous anomaly. It's where an artery that's abnormally large and tortuous penetrates the stomach wall near the lesser curvature, but without the normal branching pattern.
So it's exposed.
It's exposed to massive mechanical stress.
Yeah.
And when it ruptures, it leads to acute, catastrophic upper GI hemorrhage. It's a real structural flaw in an otherwise flawless supply network.
Moving to venous drainage, this system is so critical because it's where we see the dangerous effects of portal hypertension.
The veins pretty much follow the arteries. They drain into either the splenic vein or the superior mesenteric vein, which then combine to form the portal vein. But the linchpin, clinically, is the left gastric vein.
Why that one specifically?
Because it drains the proximal stomach and the distal esophagus, and it connects directly into the portal vein system.
And because of that direct connection, the distal esophagus is a major portosystemic anastomosis site.
Exactly. So if portal pressure rises chronically, say from liver cirrhosis, the blood has nowhere to go. It backs up. It forces these delicate veins to dilate into the lumen, and that's what forms the extremely high-risk esophageal and gastric varices.
And a rupture is a huge emergency.
A massive medical emergency.
Yeah.
And what's interesting is you can get isolated gastric varices if just the splenic vein gets thrombosed, maybe from pancreatitis next door. Since the short gastric veins drain into the splenic vein, a blockage there backs blood up specifically into the fundus.
Now, for the control system that manages this whole operation, the innervation and motility.
Autonomic control governs everything. The parasympathetic supply comes from the vagus nerves, those trunks we discussed earlier. They are secretomotor to the mucosa and motor to the musculature. And critically, they coordinate the relaxation of the pyloric sphincter right when the stomach needs to empty.
And they counterbalance to that.
That's the sympathetic supply, coming from T5 through T12 via the splanchnic nerves. Sympathetic activity inhibits motility, causes vasoconstriction, and constricts the pylorus. It basically puts the brakes on digestion.
Right.
And what's crucial for the patient is that pain from the stomach is poorly localized. Because it's a foregut derivative, the pain is generally referred vaguely to the epigastric region.
Let's shrink down to the cellular level, the microstructure inside those gastric glands. Which cells are doing the heavy lifting of digestion?
You need to look deep inside the principal gastric glands in the body and fundus. Two types of cells really dominate. First, you have the large, highly metabolic parietal or oxyntic cells. They produce two absolutely essential things: highly acidic gastric acid, HCl, and intrinsic factor, which is mandatory for vitamin B12 absorption later on.
And the digestive enzymes themselves.
Those come from the chief or peptic cells. They're found lower down near the base of the glands, and they're the source of enzymes like pepsin, a powerful protease, and lipase. And even deeper, you find various neuroendocrine cells like G cells making gastrin and D cells making somatostatin, which basically control the whole secretory process.
Finally, let's go back to the muscle that provides all the mechanical force. The muscularis externa has 3 layers, which is unique.
It is unique in the GI tract. It has an innermost oblique layer, then a circular layer, and then an outer longitudinal layer. And it's that middle circular layer that undergoes this massive thickening in the distal stomach to form that palpable, powerful ring, the pyloric sphincter.
Which acts like a valve.
A very effective valve regulating outflow.
And that muscular structure is what allows for the 2 distinct functions of gastric motility, right?
Correct. The proximal stomach, the fundus and body, it acts as a storage reservoir. It just relaxes to accommodate food. But the distal stomach is the grinder. It uses powerful rhythmic contractions, about 3 a minute, to mechanically break down food. And that tight pyloric sphincter ensures only liquids and tiny solids get through. Everything else gets shot back for more processing.
This has been a phenomenal, detailed mapping of the upper GI tract's entry point. We've covered the short, surgically critical abdominal esophagus, the complex lower esophageal sphincter, and the richly vascular layered anatomy of the stomach.
And so what we hear is profound. Understanding these deep spatial relationships, especially the clock positions of those vagal trunks and the vast vascular arcades, is foundational for everything, from diagnosing GRD to understanding variceal bleeding and the precision needed for surgical oncology like a D1, D2 lymphadenectomy.
The resilience built into that arterial system is, I think, the most impressive feature of this whole region.
It is truly remarkable.
Which leaves us with one provocative thought for you to consider. Given the stomach's extraordinary arterial resilience, that supply from the coeliac trunk forming 2 continuous arcades, what specific physiological event, short of a massive direct trauma, would be required to cause critical ischemia of the stomach wall? Think about just how many vessels would need to be simultaneously blocked to overcome that incredible redundancy. That's it for this deep dive. Thank you for joining us as we unpacked the abdominal, esophagus, and stomach. We'll see you next time.